Hello and thank you to everybody for joining us here today on this very important topic for Living Organ Donation Week on expectations versus reality, the long-term effects of living kidney donation on donors. Before we begin, we would like to recognise the Indigenous land that we are on. Inspired by the 94 recommended calls to action made by the Truth and Reconciliation Commission of Canada, land acknowledgements are a necessary first step toward honouring the original occupants of a place. They can also help Canadians to recognise and respect Indigenous peoples' inherent kinship beliefs when it comes to the land, especially since those beliefs were restricted for so long. I would like to acknowledge that I am located in Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples. It is covered by Treaty 13 signed with the Mississaugas of the Credit and is still home to many First Nation, Inuit, and Métis peoples. Recognising that we all work and live in various places, and that you may be joining us from a different traditional Indigenous territory, I encourage everybody to take a moment to reflect on that and acknowledge it. If you know the territory in which you are situated, I invite you to acknowledge it in the chat. The Kidney Foundation would like to thank our sponsors of the 2022 online seminar series: GlaxoSmithKline, Horizon, Janssen, Otsuka, Paladin, and Takeda. As part of Living Donation Week 2022, the Kidney Foundation of Canada is excited to host this very important webinar. The webinar will begin with presentations by Dr. Sunita Singh, followed by Dr. Amit Garg. Our patient partners Francine Girard-Griffith, Bob Mcrae, and Sylvie Charbonneau will then share their journeys as living donors. A Q&A fireside chat will follow to conclude this webinar. You are all encouraged to bring questions and join us in the conversation. The information presented in today's webinar is current as of today, September 13, 2022. The material shared in this presentation is not intended to be medical advice. You should speak to your doctor or care team about your own individual situation. This information is intended for a Canadian audience.
Les informations partagées dans ce webinaire sont à jour en date d'aujourd'hui, le 13 septembre 2022. Le matériel partagé dans cette présentation n'est pas destiné à remplacer un avis médical. Vous devriez parler à votre médecin de votre situation personnelle. Cette information est destinée à un public canadien.
We are thrilled to be able to introduce our speakers today, and we sincerely thank you for being here to share this valuable information. Our first speaker today is Dr. Sunita Singh. Dr. Singh is a transplant nephrologist in the Division of Nephrology and the Medical Director of the Living Kidney Donation Program at Toronto General Hospital, part of the University Health Network. She is also an Assistant Professor of Medicine at the University of Toronto. Dr. Singh completed medical school at the University of Toronto and internal medicine and chief medical residency at the University of British Columbia. She returned to Toronto to complete a Master of Science in Clinical Epidemiology and Healthcare Research, as well as additional fellowship training in kidney transplantation and advanced diabetes care. Dr. Singh's research interests are focused on the evaluation and follow-up of living kidney donors, as well as the management of diabetes in kidney transplant recipients. I'll pass you over to Dr. Singh. Thank you so much again for joining us.
Thank you very much, Lydia, for that kind introduction. Terrific. Well, welcome everyone, and it's a pleasure to speak to you today on this very important topic on the long-term effects of living kidney donation. The objectives of my presentation today will be to review the living kidney donor evaluation process and some general eligibility criteria. Thanks again for joining us. So the objectives of my presentation today will be to review the living kidney donor evaluation process, as well as some general eligibility criteria surrounding kidney donation. I'll be discussing some transplant options for donors and recipients who are incompatible, and also finish off by reviewing some post-donation care. Next slide. So we know that kidney disease in Canada is very common. In fact, 1 in 10 Canadians have chronic kidney disease. That's about 4 million people. And 50,000 Canadians have end-stage kidney disease or kidney failure, with diabetes being the most common cause of kidney failure. There are several treatment options for kidney failure, being kidney transplantation or dialysis. But certainly between the two, we typically recommend kidney transplantation as the treatment of choice for kidney failure. Next slide. And the reason that recommendation is made is that for the vast majority of recipients, there is an increase in life expectancy with a kidney transplant as compared to chronic dialysis therapy. Kidney transplantation also does allow for an improvement in quality of life, which can mean freedom from dialysis treatments, certain dietary freedoms, freedom to travel, and also possibility of pregnancy if wished, and also the potential for return to the workforce. Next slide. We know that kidney transplants can occur from donors from living donors as well as deceased donors, but generally between the two, living kidney donation is preferred, or living kidney donor transplant is preferred, I should say. There's several reasons for this. Between a living kidney donor transplant and a deceased donor transplant, there is a difference in long-term dialysis-free survival. And what this means is that there's a longer duration of time that people are alive with a functioning kidney transplant off dialysis if they receive a kidney from a living donor as compared to a deceased donor. Also, many patients who are not yet on dialysis can potentially avoid beginning dialysis if they have a living kidney donor. Or for those who are on dialysis, their duration of treatment can be shortened with a living donor. In many cases, the duration of hospital stay is shorter for recipients of living donor kidney transplants as compared to deceased donor kidney transplants. And kidneys tend to start working sooner or quicker if the organ is a living donor. And importantly, surgery can be scheduled electively at a time that's convenient for the donor and the recipient. Next slide. In order to determine if somebody is a suitable kidney donor, they do have to go through an evaluation process. The next few slides will cover some general principles about living kidney donor evaluation. Next slide. Some key principles to remember is that living kidney donors undergo a very rigorous evaluation and selection process, and that's because the safety of the donor is paramount. And the objective here of the evaluation is to look at all of the characteristics of a particular individual who wants to donate to determine if they are at low risk of both short-term and long-term complications from donation. I think we all can acknowledge that a surgical procedure can never have zero risk. The objective here is to select low risk, and the decision for most programs is to look at an individual, determine the level of risk, and to determine if that's an acceptable amount of risk to take to help somebody in need. Donation, importantly, has to be altruistic and voluntary. There can't be any coercion or pressure, and people have to be willing to do this voluntarily. Next slide. What surprises many is that not all people who put their name forward or refer themselves to a donation program go on to donate. At my particular center here in Toronto, for every 5 referrals that we receive, only 1 eventually goes on to be a living kidney donor. And there are multiple reasons for this, from multiple donors being coming forward for one particular recipient, or alternatively, a medical issue that is identified during the evaluation process. For many people, they may have never been aware of that medical issue, but that medical issue is sometimes prohibitive to donation. So as a result, some recipients may need more than 1 donor to be evaluated through the program prior to transplant taking place. Next slide. This is just a general slide of the evaluation process, and there's some variability in terms of the order of testing from program to program across the country, but the principles generally are the same across most programs. The first step typically involves a candidate contacting the program either via telephone or through a referral, a questionnaire, and answering several questions about their health to determine if there's any obvious reasons why they can't proceed with evaluation as a living kidney donor. If there are no reasons that evaluation can't take place, donors often then begin the evaluation process with laboratory testing. So that's typically either both blood testing and urine testing. First as a screen for general health, and also as a screen for kidney function as well. If that testing is suitable, then the next phase of evaluation typically takes place, which includes imaging testing from chest x-rays to CT scans of the abdomen, as well as consultations with social workers and coordinators. Testing in certain programs for the heart also takes place. And then finally, an assessment with a nephrologist to determine suitability. It's important to keep in mind that at any point throughout this evaluation process, donor candidates may be found unsuitable to donate. When a nephrologist sees a patient to determine whether they're a suitable kidney donor, either they can be determined suitable or unsuitable. And in some circumstances, further investigation or treatments are required. So as an example of further testing that may be requested could include genetic testing, kidney biopsy, or even certain lifestyle modifications such as smoking cessation or weight loss. And depending on what is required in the testing that it's needed, this can certainly extend a donor evaluation process, depending on the turnaround time of what is required. As well as part of the evaluation process, labs are drawn for a cross-match test, which is a test to determine compatibility between donor and recipient, which is very important in terms of determining if a donor can donate directly to their intended recipient. Next slide. The process of testing donors typically, as I mentioned, can vary from program to program, but the principles hold for both donors who are in Canada as well as outside of Canada. However, there's some nuances for donors who are identified as being out of country. Many individuals will have family members, friends, relatives in other countries who want to donate to them. Typically, what will occur in those circumstances is that preliminary testing will be conducted in that home country and then reviewed by the donation program to determine if the donor is suitable to travel to Canada to be evaluated further as a kidney donor. Depending on the country, a visa may be required to travel to Canada to complete the evaluation. And certainly programs will provide the necessary supporting letters and information so a visa can be obtained. However, depending on the donor's citizenship or the potential donor's citizenship, the success of obtaining a visa is variable and ultimately really lies in the hands of the government. If a donor is able to get to Canada, the remainder of the evaluation is completed in Canada. There are reimbursement programs to reimburse the costs for donors who do travel here, and most of the Canadian evaluation is covered by the healthcare system. Naturally, as one can imagine, the COVID-19 pandemic has disrupted the process significantly, although we hope to resume normal operations in the near future. Next slide. Now, in terms of donors who can and cannot donate, there's certain absolute contraindications, which means that there's certain reasons why people absolutely cannot donate. So these include the following: a donor who's less than 18 years of age, a donor with or a potential donor with a history of heart disease, such as heart attack, heart failure, or stroke. Any potential donor with a history of active cancer cannot donate. This includes a history of melanoma, irrespective of the time frame. There's also a contraindication to donation if someone has an active or untreated infection or an active psychiatric condition or a substance use disorder that has not been treated, as well as type 1 or type 2 diabetes. Next slide. There are certain common scenarios, however, that do come up, and I would like to cover some of those today. Certainly, we want donors to be healthy individuals, but there's lots of scenarios where people are healthy and they may have one or two medical conditions that are well controlled, and they still may be considered suitable for donation in those circumstances. So, for example, potential donors with high blood pressure may be suitable to donate if they're over 40 years of age. The blood pressure is well controlled on one or two medications, and there's no evidence of any damage to organs, such as the heart, the brain, or the kidneys. Obese donors can also be suitable to donate. This really depends on the donor's risk factors for kidney disease. And this is assessed usually on a case-by-case basis. So obesity is not typically assessed in isolation alone. And also admittedly, the BMI is not always the best metric to assess obesity. And this is why this nephrology consult is important in terms of determining suitability of donors with obesity. Kidney stones is also another common scenario, and individuals who have had kidney stones may be suitable to donate if their risk of having another stone event is low. And that may depend on multiple factors, including the age of the potential donor, the last episode of having a kidney stone, or metabolic abnormalities. So these may be abnormalities in the urine that may predispose someone to getting a stone. So just important to realize that these scenarios are evaluated by the donor team and the nephrologist, and really is a collective assessment of all of the risk factors of an individual. Next slide. There are some special circumstances that I wanted to cover, in particular when it comes to incompatible donors and recipients. Next slide. So donors and recipients can be incompatible if they are either blood group incompatible or incompatible based on tissue, or what we call HLA incompatibility, which means that the recipients may have antibodies towards the proteins of the donor, whereby a direct donation may not be possible. In the vast majority of these circumstances, we do recommend the Kidney Pair Donation Program, which is a Canada-wide program that's operated by Canadian Blood Services. And it's effectively a matching program for pairs that are not compatible, where incompatible pairs go into a program and alternate matches are found in order to provide a platform for a kidney swap. And I'll show you some diagrams to better illustrate this program in the next few slides. Match cycles do occur 3 times per year, and chains of varying lengths are created. Also to keep in mind, I won't be covering this today, but there are other options for incompatible pairs, such as list exchange and desensitization. But by and large, the pair donation program is typically the best choice for most scenarios, and that's why that is typically the program that's recommended first. Next slide. So as an example of what may occur in an KPD program chain, so this is an example of a closed chain. What you can see here is that there's 3 pairs that are not compatible: pair A, pair B, pair C. However, in the algorithm or in the program, they're able to match with other individuals. So donor A is compatible with recipient B, donor B is compatible with recipient C, and donor C is compatible with recipient A. And therefore, a chain is created, and effectively a swap of organs is organized such that everybody who's initially incompatible ends up receiving a transplant. Next slide. Another example of a chain that can be created in the KPD program is a domino chain. This is a slightly different chain because it's triggered by a non-directed anonymous donor. This is an individual who's come forward with no particular intended recipient in mind who wishes to donate a kidney. And these anonymous donors are incredibly important in the Kidney Pair program, Kidney Pair Donation Program, and the success of the program, because they can trigger chains. And you can see here that an anonymous donor goes on to donate to recipient A. The donor from the pair A donates to recipient B, and the donor from the pair B goes on to donate to an individual on the waiting list. So non-directed anonymous donor here has been able to trigger a chain of transplants, and rather than donating to one individual, rather than benefiting one individual, multiple individuals are benefited by one donation. Next slide. After donation has taken place, it's important to know that post-donation care is an important part of the care of a kidney donor. Next slide. Hospitalization typically for most donors is quite short. Typically the length of stay is between 3 to 5 days. Fortunately, the complications from surgery are rare. There is a very, very small risk of death from a general anesthetic, between 0.01 to 0.03%. So that is a minuscule risk. So to put it in another way, it's 1 out of 10,000 donors, or 3 out of 10,000 donors, depending on what study you look at. Fortunately, the major complications are relatively rare. From a recent Canadian cohort, major complications occur approximately 1% of the time. That includes major bleeding, organ injury, blood clots, or severe infections. But the most common issue, typically post-operatively, are bowel motility issues, which means that the bowel is slow to start moving, or constipation post-donation. These are things that can certainly be managed, and that is often what donors will experience in the first week after donation. And pain control also is an important issue to manage post-donation. Most donors will either be able to be managed on Tylenol, or sometimes Tylenol 3 or Percocet. Important to note that driving should not occur when narcotics are being used. But one of the important key messages is that anti-inflammatory medications should not be used in kidney donors, both in the short and the long term, because of their potential kidney effects in the setting of a single kidney. Next slide. Typically, we recommend 4 to 6 weeks off recovery. What is often a surprise to many donors who have never had a surgical procedure before, a major abdominal surgical procedure before, is that fatigue is quite common. And this is particularly true in the first few weeks post-donation. But that generally does improve. Usually by week 3, there's a significant improvement in fatigue. Walking can be resumed as soon as the donor feels ready to do so, and increased as tolerated. Generally, no heavy lifting of more than 10 pounds is recommended for the first 6 weeks post-donation to ensure adequate healing of the incisions. And there's for most Canadian programs, there's a follow-up with a surgeon to ensure that healing is going well, as well as a kidney specialist to review kidney function after donation. Next slide. Some important things to keep in mind is that there's no specific diet that is required after donation. We recommend a healthy diet for all donors, but there's nothing specifically that needs to be modified because of donation. And there's no specific medications that are required after recovery has taken place for donors. The exception to this is if the donor does develop high blood pressure, which I believe Dr. Garg will be speaking about in his presentation. Medications may be required for that. Typically, donors are advised to follow general population guidelines, and this is true also for vaccination recommendations. So donors are eligible for all vaccinations, including COVID vaccine recommendations. I'm often asked of the risk of COVID in donors. Data will certainly emerge over time on this aspect, but it doesn't appear that donors have any greater risk than the general population of COVID. In the reports thus far, most donors do have mild illness. This is typically because donors are generally very healthy individuals. Naturally, though, if donors do develop issues like kidney disease or kidney failure, which is incredibly rare, or things like diabetes, this may alter the risk of COVID infection naturally, but donation in itself doesn't seem to affect COVID risk in any meaningful way. Donors should have annual follow-up for life, and this is typically done through their family physician or general practitioner. And that's really to screen for the long-term effects of kidney donation, which you'll be hearing about in the next presentation. But typically, what is monitored is blood pressure. Kidney function naturally is important to monitor. We know that kidney function can fluctuate as well post-donation, and fluctuations in creatinine and in GFR are common. And it's not unusual also to see that the GFR, or the glomerular filtration rate, which is a calculated metric that's an estimate of how much kidney function there is left in a donor, can often be underestimated based on the formulas that are typically used. So typically, donor nephrologists will provide a range of what a normal post-donation creatinine will be, which is typically higher than what one started out with before donation. But it is normal to see some fluctuations depending on hydration status, as well as lab variation. Also, annual follow-up is important to screen for risk factors for kidney disease and to review things like healthy body weight, smoking, and other risk factors like high cholesterol, as well as, of course, to screen for psychosocial well-being. The vast majority of donors have excellent psychosocial outcomes, but there are some that can experience some psychosocial issues post-donation, particularly if there's issues with the recipient, and that's an important part of follow-up as well. You'll be hearing more about long-term things to screen for as well in the next presentation. So just to summarize, I think I've conveyed to you that living kidney donor transplantation is the preferred treatment option for kidney failure, that the eligibility for living kidney donation is determined after a rigorous evaluation. This is because donor safety is paramount. And in healthy, well-selected individuals, living kidney donation carries very low risks. And with that, I will stop, turn it back over to Lydia, and thank you very much for your attention.
Thank you so much, Dr. Singh. Really appreciate that valuable information for living donors. And I see that we've started getting some Q&As coming through the box, so we will save the questions till the end of the presentations, but we will be addressing those for you as well as we go through. Now I'll introduce our second speaker, Dr. Amit Garg. Dr. Garg is a professor of medicine at the Division of Nephrology and Epidemiology and Biostatistics at Western University in London, Ontario. He's the Associate Dean, Clinical Research Role at Western University. He has served as the medical director of the Living Donor Program at the London Health Sciences Centre for 15 years and is a past president of the Canadian Society of Nephrology. He serves as the ICES Provincial Kidney Dialysis and Transplantation Program Lead and the Provincial Medical Lead, Access to Kidney Transplantation for the Ontario Renal Network. He is a scientist at the Lawson Health Research Institute and at ICES, and an associate scientist at the Population Health Research Institute. Dr. Garg has mentored and trained future kidney researchers and was the recipient of the Kidney Foundation's 2021 Medal for Research Excellence. I'm going to hand this over to you, Dr. Garg.
So disclosures, in terms of disclosures, some of the work we've had has been funded by several agencies, including the Government of Canada, and Astellas has provided partnership funding in those grants, amongst other granting agencies. Advance the slides. The presentation today is for a broad audience, including a non-medical audience. The next slide should be a picture of a dialysis unit. So, as health professionals, we often go into the dialysis unit, coffee in hand, to do rounds. And here you have a picture on the following slide of one of your favorite patients. He's always very kind. He sometimes tells you occasionally an off-color joke that makes you laugh. And then during your rounds, you ask this question, if you advance the slides. Doctor, my daughter wants to give me one of her kidneys. What are the risks to her if I accept this offer? Next slide, risks to the living donor. And you heard Dr. Singh talk about this briefly. But when we think about the risks of the living donor, we think about the risks in the evaluation process, if you advance the slide, in the perioperative period, and then long-term risks. And when we think about long-term risks, we're thinking about medical, psychological, or financial risks. Next slide says, see the big picture, because when we say that, advance the slide, we have to consider risks in the context that living kidney donation is an important treatment option for kidney failure that clearly benefits many families in society. And so you can't look at these risks in isolation, you're looking about the risks in the context of also the benefits. Next slide, please. And you should see a map here. And when we think about living kidney donation in a global context, this is statistics a bit dated, but on the map you see in shaded gray all countries of the world where living donation is done. It's done in over 90 countries, and there's over 30,000 living kidney donor transplants registered each year across countries. Next slide. So in terms of the benefits of living kidney donor transplants, again, you've heard some of these things from Dr. Singh. Some would say it's a recommended treatment option for kidney failure for transplant-eligible individuals. Provinces like British Columbia have a transplant first initiative. And the reason for that is compared to dialysis, it increases the recipient's life expectancy and quality of life and reduces healthcare costs. Every 100 kidney transplants save the healthcare system about $20 million. And compared to deceased donor transplant, you have decreased waiting time for transplant. And even if you get a deceased donor transplant on the same day as a living kidney donor transplant, we see that living kidney donor transplants result in better graft and recipient survival. This is a meaningful event for many donors, and they feel very good about having helped a loved one. Next slide. But the kidney transplant is like a battery. It doesn't last forever. And so when we think about the expected graft survival, we're saying that the kidney is working 95 to 98% in 1 year, 80 to 85% at 5 years, and the median graft survival is about 15 to 18 years. So flipping those statistics around, there's a small chance that kidney will not take or last a year. It's not common, but occasionally happens. And when we talk to donors who've been in this situation, of course, it's extremely disappointing, but it's like life, where you make decisions based on the best possible information, where we think is likely going to happen. And donors really haven't had regrets when they've made careful decisions with the understanding that the probability of this working out is quite high. Next slide, please. So when we talk about the medical risks to living kidney donation, we're typically talking about studies that have the following design. Do individuals who donate a kidney compared to a group of people who don't donate a kidney have a higher risk of various outcomes. when they're followed for many years after donation. And the reason that this comparison group is important is that as we age, we all know that we're all going to develop health conditions. And is that rate of developing health conditions similar to what would occur in anyone who's getting older, or is there an increased risk related to donation? To advance the slide, it says the word observational studies. And so the next key concept is that our best estimate of effects in medicine come from large, multi-center, randomized controlled trials. And what that is the process by which by chance alone, people go into group A or group B. And then when we look at the differences between the two groups, we can say it's due to the, in this case, the surgery. But you can't randomly allocate people or randomize them to receiving donations. So we have observational studies to guide how we think about risks. Next slide, please. So one of the key things in this literature, the next concept, is we're comparing donors to a group of non-donors. And if you advance the slide, the debate in medical circles is, are we really comparing apples versus apples here? Or are we comparing apples versus pears? Because you can imagine people who donate a kidney go through a rigorous set of testing to confirm they're in good health prior to donation. And no matter how you set up your non-donor group, you won't have that same level of investigation. Also, we do know that people who donate often have family relationships with the person with kidney disease and kidney failure. And could there be genetic predisposition, or could there be environmental factors and lifestyle factors, so that it's not really due to the donation, but due to other factors that make the donors different than non-donors. So if you advance the slide, when you look at this literature, it's been an ongoing issue, including today in recent systematic reviews and meta-analyses, where they look at the totality of the evidence, that there's strong concerns about study quality in this area. Next slide. And so you should see a picture of a set of twins on this. And when we have someone become a kidney donor, they have to live with one kidney for the remainder of their life. And sometimes we're evaluating people who are in their 20s or 30s. And the next thing to appreciate is that because living donor transplant became more popular in the last recent decades, we really have very limited data on 40-plus year outcomes. So the first successful kidney transplant occurred in 1954. The donor at that time was 23. It was done by Dr. Joseph Mcrae, for which he was awarded a Nobel Prize. The donor in this case is a gentleman named Ronald here. It's been written up in medical literature where he died at the age of 79, but he did have kidney failure in those last decade of life. And so we acknowledge that we don't have great data on more than 40-year outcomes. Next slide. Also, final concept I want to leave with you in terms of interpreting this literature is that, are we talking about relative risk, or are we talking about absolute risk? And everyone would tell you that it's the absolute risk that's the most important. What do I mean by that? If I buy, let's say, one lottery ticket, I have a 1 in 1,000 chance of winning the lottery. And then if I buy 10 lottery tickets, I have a 10 times relative chance of winning the lottery. But that's not really that relevant. It's more relevant, am I likely to win the lottery or not likely to win the lottery? And in this situation, I'm still have a very small chance, of a 1% chance of winning the lottery. So when we think about risk, we're thinking about absolute risk, ideally. Advance the slide. So again, back to this question, doctor, my daughter wants to give me one of her kidneys. What are the risks if I accept this offer? Understanding now what are the considerations and limitations of the literature. But having said that, next slide. We obtain consent from donor candidates to participate in the evaluation process. One, we do a CT angiogram to look at the blood vessels of the kidneys and look at the kidneys. And that has a small risk of IV contrast, but that's pretty manageable. It's quite low. But there are occasional things that occur during the evaluation process that have implications. We sometimes find health conditions for the first time that may impact the insurability of the donor candidate. We might find infectious diseases because we screen carefully for many infectious diseases because we don't want to transmit something from the donor to the recipient. And if we do find something, those are reportable diseases to public health authorities. And very occasionally we come across misdistributed paternity. It's happened to me a few times in my last 20 years, and you need to have a policy in your program to consider this. And in the general population, it's felt to occur maybe 2% of the time, 2 to 3% of the time, where father-child relationships aren't really truly the father. And so this is just giving you some insight of what occurs when you're evaluating living kidney donors. It occurs about 1% of the time. Many programs have a policy where that if this is not going to affect the donor outcome, with patient consent, donor recipient consent is not disclosed, but it's something that we as health professionals come across. Next slide, perioperative risks. So you heard this from Dr. Singh. There's a broad concept. The death rate around donation is 1 in 3,000. If you're older with health conditions, perhaps it's 1 in 2,000. So it's pretty uncommon, but have donor deaths occurred in Canada? Yes. And is that extremely distressing and tragic from multiple perspectives? Yes. But it's pretty uncommon for it to occur. The risk of a serious perioperative complication, which we worry about, like a blood clot or serious infection, again, is occurring about 1% of the time. But most people are going home in a few days with these keyhole surgeries. We really say they're back to reasonable function in 6 weeks and full function in about 3 months. That's the information we give to donor candidates. But I do, in my own evaluations, I've evaluated maybe 700 donor candidates in my career so far. I do warn them that this is a surgery, and so make sure your supports are in place and be prepared that you're going to have some pain and some other things going through this process. Next slide. Psychological considerations for living donors. So the literature overall indicates that donor candidates feel this is a very worthwhile thing to do, and their psychological health is similar or better than if they didn't donate. Are there occasional exceptions to this? Yes. Have we come across those exceptions? Yes, in practice. But almost always the psychological considerations are good. And even in those circumstances where the recipient, the transplant kidney didn't do well, generally people, as I mentioned, don't have regrets. The donor candidate and the donor does have to be aware that this is a gift. And sometimes you can imagine if someone's been living with kidney failure and it's been a dark time in their life and they get the transplant, sometimes they want to forget that part. So sometimes it doesn't happen often, but occasionally the person who received the kidney doesn't want to think about that time when they were very ill and they become a bit distant to the donor, or they might be in fact living life a bit. And the donor has to be prepared that they're giving this gift with no expectations of the recipient in terms of how they live afterwards. Next slide, please. We do acknowledge that donors incur costs that are attributable to donations. They have to travel to the hospital for their assessment. They might need accommodations. There might be some incidental medical considerations. There's lost income, dependent care, housework, etc. So we've quantified these costs in several studies, and you may know that there are government programs that help offset these costs, and we've quantified the gap in those programs. And overall, over the last, I would say 2 decades, we've tried to make meaningful progress so that ideally donors are not incurring the substantial costs related to this process. Next slide. Occasionally, donor candidates will ask, will this impact their insurability? And based on some work we've done, at least for life insurance in Canada, because we all have universal health care for major medical things other than drugs, we don't find that life insurance, your ability to get life insurance or your premiums should be affected by donation. And I would say if that does occur, we could highlight this because it would be very bad PR for insurance companies for it to be known that they're underwriting on donation. And the data doesn't support this. Again, if anything, donor candidates living longer than the general population because they've been selected to be in good health. Next slide, please. In terms of outcomes of premature cardiovascular disease or death, almost all of the studies suggest that this risk isn't higher. There occasionally is like a one or two studies, particularly from Scandinavian countries, that have alluded to the fact that there might be high risk, but most of the literature is suggesting there's no higher risk, that donors live just as long, and that there's no high risk of cardiovascular disease. Next slide, please. Donors developing kidney failure. So when you donate a kidney, it turns out you don't lose 50% of your kidney function. You're losing about 25 to 40% of your kidney function because the other kidney does compensate. But particularly for older donors and even for younger donors many decades later, they have to be aware that sometimes these lab reports that you get say chronic kidney disease on them, and they may get that when they have laboratory tests post-donation, years following donation. And it's important to reassure people that if they do see that and their other parameters of kidney health are good, this probably does not have the same prognostic significance, and it's not through a disease process that they're getting this loss of kidney function. But as Dr. King mentioned, it is very important for donor candidates to get regular health assessments once a year, assessing the level of kidney function, assessing if there's proteinuria, assessing the blood pressure, so that if we do find something, we get on top of it earlier. Now, could the person donating kidney be at higher risk of developing kidney failure themselves, because they're going to have to go through life with one kidney? And particularly the average age of a donor candidate is 40. We can't predict what's necessarily going to happen over the next 40, 50 years. The median life expectancy of a woman in Canada is around 85 currently. For men, it's about 80. So someone has to live 50 years with one kidney. Is it possible that they might develop a health condition in the next 50 years that could impact their remaining kidney? Yes. Will they have less reserve? That would occur? Yes. And in relative terms, there is a suggestion that the risk of kidney failure in the donor is higher compared to non-donors. But going again about in terms of that absolute consideration, the chance of someone having this outcome, like the chance of them winning this bad lottery, is very low. And it's been quantified that risk is still been less than 1% at 15 years. Next slide, please. The kidneys regulate salt and water in your body, and so people have been concerned that blood pressure may increase after donation. The literature is conflicting, but there is some data to support that blood pressure does rise after donation. In people who don't donate, we know that hypertension is very common. They say 60% of Canadians will have hypertension by the age of 60, 70% by the age of 70, and blood pressure might be occurring earlier if you're a donor. So it's important to monitor this after donation. And of course, this is treatable with medications. There's also some data that suggests that the amount of protein that's in the urine may increase after donation as well. Next slide, please. To advance this, women frequently ask whether donation will have an impact on their ability to have children. And so this has also been looked at. And generally, the data would suggest that many women, most women, can have healthy children after donation. As I mentioned, the kidneys regulate salt and water in your body, and there is a suggestion that blood pressure may rise in pregnancy with donation. So generally, this concept of developing high blood pressure in pregnancy and/or like this toxemia of pregnancy occurs maybe in 1 in 20 or 1 in 10 women, depending on their age at the time of pregnancy, and that might be double that risk if they become donors. So they need to be watched carefully, but in no uncertain terms, women, many donors have gone on to have children without any issues. And then the final slide here is some additional considerations when we talk about risk in living kidney donation. So again, there's some conceptual things. So one is the information in living kidney donation continues to be updated. I think about the last 2 decades when I've been in practice, and there's more information been available. And I must confess, we as a medical community haven't done a great job contacting prior donors to let them know about this new information. So webinars like this, I think, are pretty important so that past donors can know the latest considerations around this, and we can continue to use best practice to keep them in good health. Next slide, please. There are also racial and ethnic considerations of living donation. And this is quite a complex area because we know there are certain segments of the population that are higher risk of kidney failure. Here we have a a picture of a First Nations gentleman. And we know that for many reasons, including related to the land acknowledgement colonization, that First Nations people have been disproportionately affected by kidney disease. And so certainly we want to foster transplantation and living kidney donation in the setting. The one thing we're also aware of is that some donors may be at higher risk of also having difficulty. So this is some data from Manitoba showing that at least in some donors, there was higher chance of developing hypertension and diabetes and follow-up amongst First Nations donors compared to white donors. And so again, this is a very nuanced, complicated area. We want to make sure everyone has access to living kidney donor transplants, but we also want to make sure we're safeguarding the risks to the donor. Next slide, please. When we're practicing medicine, we're now using individualized risk calculators to better ascertain post-donation outcomes. So there's several of these calculators available. Here's one of them that I was personally involved with, where we put in the characteristics of the donor candidate just to try to understand what happens to them. So you advance the slide. This particular calculator talks about estimating the risk of kidney failure post-donation. And so you can be more quantifiable on what likely can happen to the person, which is a more defensible way to practice. In the next slide here, you have a picture of a young man getting a bit heavier as he gets older. And so we acknowledge as health professionals when we're evaluating people to donate kidneys. Think about it, if you ever gone to your high school reunion and if you saw someone like 30 years later, sometimes some of them change quite a bit in that time. Whereas if you see someone who's 50, generally they're looking pretty similar at the age of 60. So particularly for young donor candidates, I think that's where the community shifted. Where, again, it's acceptable after the age 18, but we're very careful in thinking about this because what is the donor evaluation really telling us at that age in terms of who can be at risk? And so that's something we think about as health professionals. The next slide, in conclusion, again, I've talked about some of the risks, but just to emphasize, living kidney donation is an important treatment option, clearly that benefits many families and societies. And if you think of my own situation, for example, if my wife needed a kidney, of course I'd want to donate it to her for many reasons, including the fact that our family quality of life gets much better if she's healthier, and because we're a close family. So again, no uncertain terms, this option is beneficial. Next slide. We do acknowledge that living kidney donors are accepting some risk, both short and long-term outcomes, than if they didn't donate. Advance the slide, but here you have someone like teetering on like above a canyon, and we really do not want to practice like this. Rather, we want, if you advance the slide, practice very safely where we really understand the risk carefully for an individual person and mitigate it. And so, and the final part of the slide is, again, I want to acknowledge many people who I've worked with over the years who helped inform thinking in this regard. On that note, I think I've ended right on time, and thank you very much.
Thank you so much, Dr. Garg, for your insights and experiences of living donors and the long-term effects of donations. We certainly have a lot of great questions coming through, so I look forward to asking you at the end of our next little series. But what I would love to do now is introduce our three remarkable living donor panelists. Our first living donor is Bob Mcrae. Welcome to you, Bob. Bob is a kidney donor and a passionate volunteer. For over 20 years, Bob has been involved annually in fundraisers in his neighbourhood until the pandemic hit. After donating one of his kidneys in 2010, he has been passionately advocating about organ donation. Since then, he has participated in a long-term study, numerous committees, symposiums and events related to organ donation in the hope of raising awareness for such an important cause that can alter someone's life. He is also the founder of Ottawa Gift of Life for organ donation. Bob, can you share how you learned about living organ donation and what motivated you to consider giving that amazing gift of life to someone anonymously?
You know, my living kidney donation basically came about because I'm so grateful for my life, and I've been trying most of my adult life to give back for having such a great life. My inspiration has come from my mother and Terry Fox. And I've always been looking for greater fulfillment. And, one day I was giving blood in Ottawa, and sitting in front of me was actually a pamphlet, Living Kidney Donation, much like these pamphlets. And I've always been a firm believer in things are meant to happen and in fate. And so I thought, well, I'm going to go ahead and I'm going to look into this. So I started looking into it, and I decided to try and find out about the risks, the processes, the care teams, and also the long-term consequences of it. Before I did that, I talked to my wife, and she was okay with that. She knows what I've always been doing, and she was on board, and so was my work, actually. I then contacted the Ottawa Hospital Living Kidney Coordinator, and found out some information from her, met with her, got lots of information. I went on the internet, I went to the library, and I looked up stories about people that had donated their kidneys. And almost all of the information that I got was so positive that, again, with my wife's support and my work support, I decided to go ahead and contacted the Ottawa Centre and started a battery of tests. And they want to confirm with you right from day one that you're doing it for altruistic reasons, that there's no money involved or cash incentive involved or no coercion, that family people would be trying to get you to donate a kidney, just to make sure that you understand all of that. And right from the beginning, you're told that at any time, should you change your mind, you can withdraw, and there won't be any questions asked. You can do that, and there's no trouble. They also tell you that during the testing, they may find some things that could disqualify you. And I was really quite surprised that they did find some things. And sure enough, my processing to donate was stopped until I saw a kidney specialist about my kidney stone they found. And most surprisingly was they determined that I had a heart problem. And so until I saw the specialist, I couldn't proceed further. But I found out the kidney stone was a signal stone. It wasn't serious. There was nothing more. My heart was actually resulting from an enlarged heart because I've always been very athletic, doing very cardio intensive activities. And so there was no trouble with my heart either. During the process, I found out, because I was in the paired program that the previous speaker was talking about, I would have to donate my kidney if I wanted to somebody who lived in Vancouver, and I was in Ottawa. But I was fine with that. So after all of these tests, I flew to Vancouver in April of 2010, about 8 months after my whole process started. My operation went incredibly well. It was a laparoscopic surgery, which, for those people that don't know, laparoscopic is basically almost like a laser type surgery. I have almost no scars. Nobody would ever be able to tell me, if they were to unfortunately see me in my bathing suit, that I ever donated a kidney, because I really have no scars. I did experience some pain for a few days, but after the operation, they give you this incredible little apparatus that you press the button, and it gives you this drip of, I'm not sure quite what it was, but it sure took away the pain, and I felt pretty good for the 2 days that I had pain. And thank goodness for that. I did experience some nausea related to the anesthetic, and some stomach cramping, and that even goes on to this day when I do things that are extremely strenuous with my stomach muscles. So I stayed in the hospital for 4 days, and because I was in Vancouver, I couldn't fly back home for at least a week, and that's just a requirement of the process. So the program put me up at a beautiful hotel in Vancouver, and all my expenses were paid, and a week later, I flew home. For the next 2 or 3 months, I actually recovered, and honestly speaking, I didn't have to stay off for 2 or 3 months, but I had lots of sick leave in the bank, and so I decided I was going to enjoy my summer and really recover well. But I could have been back at work in a month, no problem at all. My work was incredible. They not only gave me the leave to be off, but they also agreed to pay for, or to look after, half of my leave, so that should something happen to me in the future and I needed that sick leave, it would be there for me. Fortunately, to date, that hasn't happened. For the first while after donating, the only thing I had to really be careful was lifting anything really heavy so that I wouldn't tear the stomach muscles or the incisions. But after about a month, I was really back on my feet, 100%, doing everything I ever have done. And 13 years later, to this day, I've really not had any serious or other health problems related to the kidney donation, or any other problems for that matter. I see my Living Kidney program annually for tests to determine my kidney function and health, as well as my own physical health. And actually, everything has still gone very, very well with that. So that's basically my experience. And since my donation, though, I've gotten involved in organ donation advocacy, both at the living donation level and at the deceased donation level to get people to register. The only other things that I would really like to say is that people that find out that I've donated a kidney, which like many donors, people don't know the people that have donated kidneys because you can't tell by looking at them, which is similar to other organ donation type things as well. But they ask, would I do it again? And the answer to that is my experience was so fantastic and was so life fulfilling, as much as other things in our lives that are so important to us, that I would do it again in a heartbeat. For people that might be listening here today and have thought about donating, and I do perk their interest, or some of the other wonderful speakers that you're going to hear, it perks their interest to look into living kidney donation. I wish you luck, and should you go on to save somebody's life or really improve somebody's life, fantastic and good for you. Je m'excuse de parler seulement en anglais ici, mais je suis disponible de répondre aux questions en français. S'il y a des gens là, I would like to thank the Kidney Foundation for this opportunity. I really think it's important that the Kidney Foundation and other organizations promote organ donation by giving people that have donated who want to the ability to share it with other people who have no idea that so many more people out there could do it if they look into it and decide to do so. So, merci beaucoup, and thank you very much.
Our second living donor speaker is Francine Girard-Griffith. Francine is a caregiver to her husband, who was diagnosed quite unexpectedly with kidney failure in June 2015. Throughout his kidney journey, Francine was always by her husband's side while he underwent in-centre hemodialysis 3 times a week and then peritoneal dialysis at home. After finding out she was a match, Francine donated one of her kidneys to her husband in April 2018. Francine, if you would like to share a few words as to why you chose to become a living donor, and what were some of the challenges that you faced? Perhaps you could also share how you stayed so positive during your journey while becoming a living donor.
Sure. Thank you, Lydia. So I'm happy to also to report that my husband is doing very well. My kidney is working very well in him. So I gave him a good one. I'm going to just go over, I think from the very beginning, I went into this feeling very positive that I should qualify as a donor, and it turned out to be a very positive experience. There were a lot of tests. I did well over 25 tests, including hematology, because I did have a blood issue that they reassured me that they would give me something to coagulate my blood, like during the surgery too, that I tend to have a bleeding problem. So that's why I required a little bit more tests. And but overall, I would say I felt pretty healthy, and I went into it feeling very positive that it would be a good outcome. And the testing was actually done over about a 4-month period when they got to that cross-match tissue typing test that Dr. Singh was talking about, where they confirmed that we were a match. So that took about 4 months, but I did have a few more tests to do after that. And it was quite something to be given a clean bill of health. And so I was 61 years old at that time. So that was pretty reassuring that I was a very healthy person. And the session with the social worker, which is also part of the workup, I knew that what I would feel after the surgery was a little bit of social isolation, and that is what happened. Anyway, I'll talk about that in terms of post-surgery. So the surgery itself went extremely well. It was uneventful. I did have a post-surgery complication. So I came out of the hospital 3 days after the surgery, and then 2 days afterwards, I actually had to go back to emergency. And that is something that Dr. Singh also talked about in terms of slow bowels. So I went back back to the hospital in ER, but they solved the problem very quickly, and it was just a result of the surgery that my bowels just weren't picking up as quickly. But again, like I said, they really gave me medication to address that. Post-surgery, I did have some fatigue, and I think it lasted more than a few months. I was quite surprised, but nothing that would prevent me from doing my usual activities. I think for me, it was probably going to bed an hour earlier than I usually would. And then listening to my body. When if my body felt, if it was telling me, oh, you need a bit of a nap, then I'm not a napper, but I would certainly pay attention to that. In terms of the social isolation, so what happened was, like, first 2 weeks, my granddaughter was the caregiver for both my husband and I, and she stayed with us for 2 weeks, and our daughter also really took care of us. And then after that, sort of the interest kind of wanes off a little bit, or your friends come to visit you at the beginning, and then a few weeks later you find yourself not being able to pick up some of your physical activities like sports or whatnot. So all of a sudden I thought, yeah, I feel a little bit alone here, but it didn't last very long. I ended up reaching out to people. I'm very much a social person, and so that was just a little bit of something that I had identified with the social worker beforehand, and it did happen. One aspect that was a surprise to me, and a sort of an expectation versus reality, which is the theme of our seminar today, I felt sadness over some of my laboratory results. And so particularly with the EGFR that we've been hearing about, that filtration rate of the kidney. When I went to the information session prior to considering being a donor, the number that stuck in my head from the presentation was that your kidney function, yes, the remaining kidney will compensate, and that on average it would, on average, most people kind of end up at 70%. So in my head, when my filtration rate ranged between 30 and 40%, I thought it really did bother me until, and it's only this year that I had a better explanation from one of my nephrologists that actually explained that the 70% is really based on 70% of what your pre-EGFR value is. And so they kept reassuring me and telling me your kidney has functioned very well, but that number had kind of stuck in my head. So I now understand that number better, and it's not an issue at all. And I do believe the nephrologists when they say that I'm doing very well and my kidney's doing well. Very quickly, lessons learned. I just wish I would have had more knowledge about some of the laboratory, like the different tests, and maybe a bit more time with the nephrologist going through that as a pre-operation consultation. I felt that the appointment was a little bit rushed, and this is a brand new area. You're not too sure what you're walking into. And I think I would have paused a little bit more and looked at the possible risk factors a bit better. So taking time to understand too how some of your lab results might change post-surgery, again, the creatinine, the EGFR. And also what I learned along the way is that some of the private labs don't interpret the data in the same way as the hospital lab. And so typically the community labs have percentages that are a little bit lower. So my EGFR, now I know if I get blood work done at a private lab, the EGFR readings are typically lower than what I would get at the hospital. So I'm trying as much as possible to get that consistency of results by going to the hospital lab. Another issue that I'm faced with now is because I can't take anti-inflammatory meds, and I have been diagnosed with a lot of arthritis in various parts of my body and can't take something like Celebrex. But again, with the nephrologist's help, I'm also exploring natural health products that the nephrologist has reviewed and said I'm okay with taking some of that. One experience I had with taking multivitamins and other health products, I was taking too much vitamin C, and that was creating too much acid in my body. And so my nephrologist took a good look at some of the different health products I was using and recommended that I reduce some of that intake. And I didn't know at the time that it was creating too much acid and affecting the kidney. So that was something that I learned. And now I just have my nephrologist review any kind of healthcare product I want to take and pass it by them. I also have been followed up by a renal dietitian, and she has provided me with the protein range, how many grams of protein I should be taking every day and staying within that range to maintain a good kidney function long term. So that's been also very, very helpful. In conclusion, the medical team was amazing. The nephrologists, the urologists, all of the technicians. It was a very good experience. What they predicted would happen like in a positive sense. And overall, it went very well. I think it's an incredible blessing to be able to give the gift of life to your loved one, in my case, of my husband. And I would do it again if I had the opportunity to. So all around, a very good experience. Thank you.
Thank you so much, Francine. Really appreciate you sharing your story and how you felt after the donation as well. And last but not least, we have Sylvie Charbonneau, who has recently retired. She's the president of the Kidney Foundation's National Board of Directors and has also served as the president of the Quebec branch of the Kidney Foundation. On a personal level, Sylvie donated a kidney to her son and is doing all she can to change the world, one kidney at a time. Sylvie, as a parent, how was the process for you to decide to donate? Were there any hesitations on your end or your son's end, especially with his mother donating to him?
Thank you, Lydia. There was no hesitation from my part. I don't think I even thought about that for 10 seconds when I heard that my son had an end-stage kidney disease and would eventually need to go on dialysis or need a transplant. To me, the solution was easy. I'm going to try to be a living donor. And I guess one of the things I learned through that process was that it was a family matter. And what I mean by that is my husband went for testing. I did some testing. Eventually, I was the one who continued the process. But at one point in time, our daughter said, if it doesn't work with you, Mom and Dad, I'll try to see if I'm compatible and I'll go through the process. And I just went like, oh, no, you're not going to do that. And she said, why? If it's good for you, it should be good for me as well. And I realized that when I said that I couldn't bear having my two kids on the surgery table at the same time. But I was asking my husband and my daughter to have their mom/spouse and brother/son on the surgery table at the same time. So one thing to consider is that if you want to go through that process, it is a family matter. And I think it brought us together very closely. I want to talk about the after, because you've heard a lot about the process before. Yes, it's long, but also it's a gift. I don't think I've ever had such an evaluation in my life. And being told that you're healthy is kind of a gift for yourself. But after the process, how did it go? And it happened for us in December of 2012. So it's going to be 10 years this year. Yes, I had some pain for the first 2 days after the surgery. Surgery happened on the Thursday and I was out back home on the Sunday. I felt some fatigue for the first couple of months. I was back in the office after 4 weeks. But if I look back, one of the things that is special in our case is my son rejected my kidney last year and he had to go on dialysis, and he was lucky enough to have a second transplant in January of this year. I guess I always knew that this could be a possibility. But when it happens, of course, I was disappointed. I was sad to see him going on dialysis. I was sad to see him going back to that stage where you have to be very careful about your diet, being tired. But I knew there were some solutions because I had gone through the process. And some other people, because I did that, some other people raised their hand and said, I want to be tested to be a living donor for your son if that's a possibility. So I think that I was able to influence other people to raise their hand to be potential living donors. The impact on me. I was 56 when I gave the kidney. I'm going to turn 66 this year. I take no medication. I have no special diet. And honestly, I think I'm on the lucky side. I was healthy, of course, but I even feel that I'm healthier today than I was before the surgery. And the reason why I say that is because my son is a swimmer, and one of the things he wanted to do is to go back to his sport after the transplant. And so one of his objectives was to join the World Transplant Games, and he was able to do that in 2015. And I went to, my husband and I, we went with him to the World Games. They were in Argentina that year. We witnessed him winning 5 medals. He was so proud, so happy. And I was sitting at the pool and I was thinking, all these people here had a transplant. They all went through a lot of physical issues. And I'm here sitting and watching, and I'm healthy. I should take care of my health more. So I went back to training. And since 2017, the living donors and the family of deceased donors are now accepted at the games. So every 2 years, I go to the games with him, and it keeps me motivated to stay healthy. So to me, this is a collateral effect on me, but I think it's a positive one. I was talking about the disappointment when he rejected the kidney. And so maybe you can think that it questioned me. But I would say that it's an extraordinary human experience. I still feel good about that, even though he rejected my kidney. At no point did I feel guilty because of that, because you know, I think I'm a positive person in life, and my way to address that was to say, at least I gave him 8 years, or a bit more, 8 years of quality of life. It was good for me too, because it motivated me to stay healthy. I was able to influence other people who decided to become living donors. And there is no impact, you know, except for the first maybe 2 months after the surgery. I had no long-term impact. And I was also part of a study. I was part of a research for 7 years after the transplant. It was a research program with McGill University here in Montreal, and I think it was London in Ontario. And they wanted to evaluate the impact of having given a kidney to your blood pressure. And so they were evaluating the blood pressure of people who gave a kidney and those who did not. And my husband and I participated in that study, and we were a good comparison because we basically have the same lifestyle. We eat the same thing mostly. And so for 7 years, I received some equipment to take my blood pressure for a whole week. I had to go for urine test and some blood tests. And I can tell you that after 7-8 years, my blood pressure is exactly the same as it was before the donation. So am I on the lucky side? I don't know, but that's my experience. One point that Dr. Garg mentioned is insurance. I can tell you I was a partner in a company, and we had insurance for the partners, and I had to raise the level of my insurance after a while because the company was worth more. My shares in the company was worth more. And I went from a risk 1 to a risk 3 just because I gave a kidney. So yes, there might be some impact on getting insurance. or on the cost of insurance, unfortunately. And I think we should advocate for this shouldn't be happening. In conclusion, the long-term impact on me are really, really minimal. Collateral impact, positive, because I feel healthier and I'm still training, running and swimming on a weekly basis. And would I do it again without any hesitation, without not even thinking about it? I would do it again, absolutely. And I'm still more motivated now to change the world one kidney at a time. Thank you.
Thank you so much, Sylvie. It's great to see that there's been no long-term effects and you're still so positive about it. That's wonderful. Now, I'm aware of the time. We do have time for a couple of questions. If we don't get to all your questions today, please do shoot us an email. The email address will be entered into the chat. So if we do not get to address your questions live, we'd be more than happy to take them offline and address them offline. I'm going to address the first question to Dr. Singh, and we've had this repeated a couple of times in regards to fatigue after donating a kidney. Would you like to just explain why some donors may experience the fatigue after donation?
Yeah, it's a good question. I think there's probably multiple factors at play. The first is, surgery triggers a whole kind of cascade of inflammatory responses that are responsible for healing, and that requires energy. And so as a result, it's not unusual to feel fatigue after, as your body works very hard to kind of repair kind of the incisions and kind of the surgical site. So that's the first thing. Sometimes some donors also have fatigue from the medications they require for pain control. So narcotics, for example, can certainly contribute, and also the sleep disturbances that may ensue from being in hospital and having to take pain medications that can sometimes result in fatigue. And also finally, some patients do lose a little bit of blood, although they may not require a transfusion. There may be a little bit of anemia at play. And that typically is responsible, all of those factors and together may be responsible for the fatigue that people experience. But the fatigue should improve. Of course, it's variable depending on donor to donor and age. I think also, in my personal experience, age does play a role in how quickly people do recover, probably because of the response of all those inflammatory mediators that are responsible for healing. But it certainly is something that should be a short-term issue as opposed to a long-term issue. Although the weeks that it takes to recover may vary from donor to donor.
Thank you. It's never just one size fits all, really. So thank you for that. I've going to ask one last question to Dr. Garg, and it's in regards to blood pressure. We're just circling back to the factors of an increasing blood pressure after donation. Is that something that is necessarily going to happen, or is it just a probability?
Yeah, thank you. It's definitely a probability. So as I went over quickly, even if people didn't donate a kidney, there is a risk of them developing high blood pressure. 60% of Canadians will develop high blood pressure at the age of 60 and 70% by the age of 70. So unfortunately, as we all get older, many of us will develop high blood pressure. And some of the studies, recognizing the limitations of the quality evidence, suggest that blood pressure goes up post-donation. But it's not 100% guaranteed. And so the most important consideration is that if someone is thinking about donation or later does donate, that they're getting a careful blood pressure measurement at least once a year and keeping an eye on their blood pressure, because high blood pressure is very treatable as well. So the probability that the risk potentially will go up based on some of the literature, and this can be watched for and actually controlled if it does happen.
Very much. Unfortunately, that's all the time that we have for questions today. But as a reminder, we are committed to providing information and educational resources. If you are after more information, please visit our website or email us at kidneyprograms@kidney.ca. We invite you to also visit Kidney Community Kitchen for recipes, information and tools. Through our regional branch offices, we offer advice and support about accessing services within the healthcare system and in the community, including the long-term effects of living donation. We remain committed to providing the information you need to protect your kidneys and to live well with any stage of kidney disease. Please contact us if you have any further questions to speak to someone in your local community.